start with Dr. Bhuvan. He's a senior vitreoretinal consultant in Bharti Eye Hospital in New Delhi and a prolific VR surgeon. He'll be speaking on optic disc pit, case-based presentation of various management techniques.
So a very good morning to all those who are here, and I would like to thank Vishal for including me in his course. And he's a very dear friend, and he was my junior in RP Center, and we have got many associations together. So I just start with my presentation. So I am talking first on the management of optic disc pit. So this is a very rare entity uh, which we encounter in our clinical practice. It is a congenital abnormality of the disc, and it mostly involves the temporal side of the disc. It's very rare, as I said, and in 10 to 15% of the cases, it is bilateral. In most of the cases, the patients are usually asymptomatic, and it is just as an incidental finding, or a patient may present with a optic disc pit maculopathy, which causes visual deterioration. It is associated with the presence of subretinal fluid macular schisis, that is in the form of intraretinal fluid. So this can happen in about 25 to 75% of the cases. So the main problem in this is the pathophysiology of the fluid. From where is the fluid coming? Whether it is coming from the vitreous cavity or it is coming from the cerebrospinal fluid. And hence there are controversies in the management also. So initially, if we go back by history, they used to do a laser along the temporal side of the disc, but usually used to stop the progression of the fluid. But however, it can also be associated with some tissue damage. Then came pars plana vitrectomy with laser and with gas tamponade, and now we have come with the concept of doing a foveal sparing IL peeling and plugging the pit with different sorts of things. It has just become like a dumping bag. So is it really required or not? So this was one of the initial videos which I of optic disc pit, which I operated. So this is the most important step, I think, in a management of optic disc. That is the induction of PVD. Usually it may be associated with vitreous schisis, so it's always better to use a triamcinolone to while inducing a PVD, because it's also difficult because of the adhesions around the disc as well as presence of vitreous schisis, as can be seen in this case. You may need repeated attempts, may need a forceps also to grab it, but once you have an opening, usually with these 25 gauge cutters, you can go very close to the retina and you can just induce the PVD. So this is the most important step, since it reduces the traction at the area of the disc, and most of the cases will resolve with this simple procedure. So just I wanted to highlight that inducing a PVD is sometimes difficult in these patients because they are young. There is presence of vitreous schisis. So just induction of PVD. Another important step is just it's very important to screen whole of the periphery before ending the case, because in this case there was a peripheral lattice degeneration with a break and a localized RD, as you can see in this hole which I just cryed. So another important trick for all VR surgeries, you have to do a screening at the end of the periphery. Otherwise, it can lead to a failed surgery or a retinal detachment post surgery. So in this case, as I said initial video, I did a mild sub-threshold laser, which is not visible at the margins of the disc, which has got a very controversial role. So this is the pre-operative pictures of the OCT, and these usually take some time to resolve, so you don't have to just hurry. Gradually the OCT pictures, it improves. As we can see, the vision is improving and the fluid is also going off. So as we can see, the connection from the optic disc has gone, and this fluid, I don't have the latest OCT, but this fluid had also disappeared and the vision improved to 6/12 in this patient. So you can see that the fluid coming from the optic disc, this area has flattened out. So do we have to do ILM peeling and the plugging of the pit in every case? So that is the main controversy. So initially, as I said, 10 out of 11 patients in a study which was done, it showed that vitrectomy with gas exchange without endolaser photocoagulation reported very good successful results. Some authors, they propagate the use of some subthreshold photocoagulation at the temporal side of the pit. It They say it creates a permanent barrier to prevent the fluid leak. So if you use a very subthreshold mild laser, it usually does not cause tissue damage and may also increase the chances of the success rate. And studies have shown that they do not cause affect the central visual acuity. Probably they just cause enlargement of the blind spot. So this is another video in which I did ILM peeling after induction of the PVD, which is the most important step. The ILM peeling should be foveal sparing because usually the retina is very thinned out and it can lead to complications like macular hole. So I'll just fast forward this video a bit. So after induction of the PVD, again injecting triamcinolone is a very good idea because you will be able to see the vitreous, as it is difficult to induce a. So this is a foveal sparing ILM peeling was done, and one of the pieces of the ILM was then plugged into the pit. Okay, so I think now the message is clear. So this was a patient who had a vision of best corrected visual acuity of 1 meter, and this was the optic disc pit with in macular schisis, presence of subretinal fluid. But what happened in this case, this video I'm highlighting because despite a foveal sparing ILM peeling, the patient developed a macular hole, and the vision did not improve. But however, the near vision improved, and so this is the problem which we can have while doing an ILM peeling. So again, as I said, since the pathophysiology is a controversy, the management is a controversy. The fluid can come either from the vitreous cavity or from the cerebrospinal fluid. So the main cause is vitropapillary traction. That is, the source of the fluid is from the vitreous cavity. If the fluid originates from the subretinal fluid, then probably going beyond a PPV is suggestible, like doing a foveal sparing ILM peeling or the plugging of the pit. Otherwise, it is not required. So as I said initially also, the pit is now like a dumping space. You can put a lot of things into it. You can put the ILM. Some of the reports are there of putting amniotic membrane or fibrin glue or an inverted ILM technique. So these are all the techniques. So again, the controversy is whether this is necessary or not. Both the techniques have demonstrated favorable long-term results. So I feel that PPV should be the first line of treatment, and if it does not succeed, then probably we can go ahead for a surgery like a ILM peeling with ILM plugging of the optic disc pit. So this is one video just to highlight that most of the cases, the problem is originating at because of the vitropapillary traction. And as you can see in this video, the vitreous was very tightly adherent to the optic disc at the site of the pit, just indicating that the main reason is because of vitropapillary traction, and the fluid is most probably coming from the vitreous cavity only, and hence no need for plugging of the ILM. So another video just highlighting the same thing. So this I'm just showing in a slow motion. You can see that the main traction, you can see this gliosis and fibrosis present at the temporal margin of the optic disc pit. So hence, when I see this, I probably decide that I will not do much for this patient. I'll just do, I'll keep it simple. I will do just a PVD induction, a PPV screening of the periphery, and injection of gas at the end of the surgery. So long-term outcomes without internal peeling have shown very good results. They showed that the vision improved to better than 6/12 or 20/40 in this study, and subretinal or intraretinal fluid was completely resolved in 12 eyes out of the 13 eyes. So just putting it all together, since there is a lack of clarity about the diagnosis, about the pathophysiology, there is no established guidelines. So in addition, the macular fluid, as I said, it's not known from where it is coming. So the gold standard still remains as a primary procedure, I think, is PPV with PVD induction. So that will prevent the complications like I just showed, resulting in a de-roofing of the fovea and macular hole formation. And ILM's plugging of the ILM is only beneficial in a selected cases, in a selected number of cases. So one of the main concerns that should be addressed is the in a plugging is also the damage to the optic nerve, the mechanical damage to the optic nerve and the neurosensory retina because of the surgical trauma we are inducing by stuffing things inside the pit. So just to conclude, PPV with PVD induction has a very high success rate of 90%, and these adjuvant procedures of peeling of the ILM, foveal sparing, and closing of the pit should only be done when the primary surgery fails. So thank you all for your attention.